introduction. I'll be presenting the sequencing in treatment in the era of upfront biological therapy in Hodgkin lymphoma. So Hodgkin lymphoma is one of the most curable cancers in human. And the best time to cure Hodgkin lymphoma is the first time. I think this is one of the main concepts that when treating Hodgkin lymphoma we should consider. So the first time to treat Hodgkin lymphoma is the best chance to cure it, and we should choose the best regimen for that. With that, also we have to consider toxicity, because most of our patients, especially in our kingdom, are young. So toxicity is a major point to consider when treating Hodgkin lymphoma. So we want to aim for cure with the least toxic regimen, and considering the financial burden of treatment as well. So why sequencing matters in 2026? Overall cure rate is 90% and even better. Relapse refractory cases around 10%, and most of these relapse refractory cases are also curable with second-line therapy and salvage treatment. Novel agents have changed the landscape of treatment with first line, second line, and beyond as well. Hodgkin lymphoma, characterized by having a universal expression of CD30, which is the target for brentuximab vedotin, and also it has a PD-1 expression, which explains the high sensitivity of PD-1 inhibition. Role of PET and PET-adapted treatment has emerged as one of the cornerstone in treatment of Hodgkin lymphoma. PET scan or PET2 negativity after 2 cycles of treatment is now the best available prognostic factor in advanced classical Hodgkin lymphoma. So patients who are PET negative after 2 cycles, they do much better than patients who are PET positive, regardless of their IPS scoring on stage and age. So PET is very crucial in treating Hodgkin lymphoma. Our understanding of the biology of Hodgkin lymphoma is also evolving. It is known that only 5 to 10% of the tumor is cancer cell. The Reed-Sternberg cell represent only small proportion of the cancer. Most of it is inflammatory cells around it. So the landscape of the biology of Hodgkin lymphoma now is probably evolving into categorizing Hodgkin lymphoma into 3 groups. A group that is inflammatory or consists of an inflammatory reaction around the Hodgkin cells, and a group that is EBV related, and a group that is oncogenic driven. These 3 groups behave differently with newer therapies. With the most resistant group is the inflammatory group. So maybe in the future we'll see not a PET-adapted approach, rather a biology-adapted approach with circulating DNA monitoring, MRD monitoring, and that would be something to look forward in the future to decide which patient deserve more aggressive treatment or more enhanced treatment. Historically, the treatment paradigm consisted of ABVD for most of the cases of advanced classical Hodgkin lymphoma, or BIACOB or escalated BIACOB as a frontline option. Patients who relapse, salvage chemotherapy, and then autologous stem cell transplantation, and then allogenic stem cell transplantation reserved for patients who are relapsing post O2 with high-risk disease. So the current approaches are changing. So for early stage favorable disease, the current approach remain similar, 2 to 4 cycles of ABVD followed by 20 gray involved field radiation. And this is driven mainly from H10, HD16, and rapid trial. So with truly favorable PET negative patients, you could omit radiation to give another 2 cycles of ABVD. This is very important when you select those patients because you will lose some PFS with those patients. So you need to select only the patients who are at risk of radiation toxicity, particularly young females who have a very favorable disease and a PET negativity. So no change in the early disease with favorable risk factors. In the early stage unfavorable disease, also probably no big change. 4 cycles of ABVD followed by 30 gray of involved field radiation. This is driven from HD11 and HD14 trial. Addition of BV or PD-1 inhibitors improve PET negativity and PFS, and we may see in the future some change in this category. However, in advanced stage classical Hodgkin lymphoma, the standard of care has changed. Historically, although recently, until 2014, probably the algorithm or the preferred regimens were either to go with the Rathil approach with ABVD 2 cycles, and then if PET negative to drop bleomycin and avoid the lung toxicity. In PET positive, we might need to escalate with escalated BIACOB. Or we go with echelon 1 approach with BV-AVD, brentuximab AVD for 6 cycles. Or we can go with HD18 or AHL 2011 approach with escalated BIACOB. In 2026, this has changed. Now, the standard of care for advanced stage classical Hodgkin lymphoma, the preferred regimens are either to go with the S1826 Nivo AVD for 6 cycles or HD21 BRICAD regimen, which include brentuximab, and it can have a shorter duration of treatment for some patients. Useful in some circumstances is to go with the Rathil approach or BV-AVD or the escalated BIACOB with the AHL 2011 protocol, de-escalation after 2 cycles to ABVD if you have a good response with PET. So we'll go through the studies that has led to this change and analyze it one by one. So key trial summaries in the beginning. For limited stage, NIVAL is a phase 2 trial that included Nivo AVD plus or minus radiation therapy for early stage disease, favorable and unfavorable, and showed progression-free survival at 3 years of 98 to 100%. So this is not yet a randomized clinical trial, so we still have a very good responses with the prior approaches. So we'll wait until we change our practice in the limited stage disease. There are other studies that are exploring the Nivo addition to AVD and chemotherapy in early stage Hodgkin lymphoma. Echelon 1 BV-AVD, we have now the 7-year follow-up, which showed an overall survival benefit, which has led to BV-AVD to be the standard of care in advanced classical Hodgkin lymphoma. HD21 compared a very good regimen in terms of efficacy, escalated BIACOB, in advanced classical Hodgkin lymphoma with BRCAD, which is an enhancement of the escalated BIACOB, with removing brentuximab, removing bleomycin and adding brentuximab, and removing brocarbazine and prednisone and adding dicarbazine, dexamethasone. S1826 is the randomized clinical trial that compared nivo-AVD to a very good regimen, the Echelon 1 regimen, BV-AVD, with excellent outcomes showing better progression-free survival at 1 and 2 years and 3 years now. So Echelon 1, just to remind you about the study and the outcomes, it's a multi-center randomized open-label phase 3 clinical trial, included patients with advanced stage classical Hodgkin lymphoma, randomizing them to either to receive brentuximab vedotin AVD versus ABVD, and the results initially showed better progression-free survival in the BV-AVD arm, and now after 7 years follow-up, it showed overall survival. And remember, it's very difficult to show an overall survival benefit in a very responsive disease to treatment. So overall survival benefit with the brentuximab AVD. Of course, febrile neutropenia and neuropathy were high in those patients. And this has resulted in adoption of first-line treatment of brentuximab containing regimens. How about PD-1 inhibitions? So checkpoint inhibitors. Again, Hodgkin lymphoma is the single most cancer that has overexpression of PD-1 and highly responsive to that. So incorporating PD-1 inhibitor in classical Hodgkin lymphoma, the main study in advanced stage classical Hodgkin lymphoma is the S1826. So nivo-AVD with the same schedule as the usual ABVD or BV-AVD versus BV-AVD. It included, this is a very probably well done clinical trial in terms of inclusion criteria. So it included everyone above age of 12 or 12 and above. It also included high-risk patients. It was a multi-center international randomized clinical trial and randomized patients to either receive nivolumab AVD for 6 cycles versus BV AVD for 6 cycles. PET was not considered during treatment, and also patients receiving brentuximab mandated to receive GCSF. Nivolumab, it was optional. Baseline characteristics were balanced in both groups, and it included high-risk patients in about a third of the patients in both groups, so IPS 4 to 7. Side effects were probably equal in both groups. More neutropenia in the nivo arm because of less use of GCSF, and more neuropathy with the BV arm as well. Immune side effects, only the thyroid dysfunction was higher in nivo. Others were not really noticeable. Treatment discontinuation was more with the brentuximab because of neutropenia mainly. And at 2 years, the PFS benefit was significantly better with nivo AVD, so 92 to 83 with BV AVD. This is now has been updated, and 3-year follow-up is available, and still the progression-free survival with nivo AVD is better compared to BV AVD, 91 to 82. It's around the same numbers so far. Not only the progression-free survival as a group, but subgroup analysis also showed all patients, younger patients, adolescent patients, older patients, they benefited from nivo-AVD. Higher risk or low risk patients, presence of symptoms is also all in favor of nivo-AVD. Overall survival benefit is the same, but it's excellent. Overall survival at 2 years is 98 to 99%, which is very reassuring for us as lymphoma physicians, as this is a very excellent outcomes in treating Hodgkin lymphoma. HD21 aimed to look and explore reducing the toxicity with escalated BIACOP with enhancing the outcomes as well. So patients were randomized to either to receive escalated BIACOP for 2 cycles or BRICAD regimen for 2 cycles, and then they will have a PET. PET negative patients will receive additional 2 cycles of the same protocol. PET positive, they will receive 4 cycles of the same protocol. This is a comparison between the 2 protocols, BRICAD and escalated BIACOP. Just simply, BRICAD is addition of brentuximab, removing bleomycin, and addition of dacarbazine instead of procarbazine, and dexamethasone instead of the prednisolone, aiming to decrease the toxicity of the steroid and the procarbazine later on, particularly infertility. The PFS was improved with BRICAD versus escalated BIACOP. BRICAD, 3 years estimated, or PFS was 95 and 94%, and escalated BIACOP 92 and 90%. So better PFS with less toxicity. Sorry, there was a slide here, but anyway, the toxicity or adverse event with BRICAD versus escalated BIACOP was significantly better. No significant admissions with neutropenia. Patients required GCSF in both groups. So some comparison between the 2 protocols, BRICAD and nivo-AVD, from HD21 and S1826. The nivo-AVD has less cytopenia, particularly anemia and thrombocytopenia, and less febrile neutropenia, and of course less neuropathy as well. In both studies, the consolidative radiation for patients who had persistent disease at end of treatment in nivo-AVD only required in less than 1% of the cases. In BRICAD, 14% required radiation. So that has led to changing in the standard of care in advanced stage classical Hodgkin lymphoma. nivo-AVD had improved PFS compared to BV-AVD in advanced stage classical Hodgkin lymphoma. nivo-AVD was well tolerated with few immune-related adverse events. Of course, we need time also to make sure that there is no delayed immune-mediated reactions. Less than 1% of patients received radiotherapy. Follow-up ongoing to assess the safety, overall survival, and side effect. Key steps toward harmonizing pediatric and adult therapy, and this is one of the few studies that included adult and pediatric in aim to unify the protocols. BRICAD improved PFS compared to escalated BIACOP in advanced stage classical Hodgkin lymphoma, and BRICAD was well tolerated with no adverse impact on gonadal function like escalated BIACOP. This is very important, especially in elderly patients, so they have lower tolerance to intensive therapy. nivo-AVD is now considered optimal in this group. very well tolerated. Sequential BV-AVD plus BV is probably effective, but I don't see and I don't see it used while the impressive results of NEVO-AVD right now. BV-NEVO chemo-free regimens under study considered in frail patients, especially that the duration of treatment or the duration of responses might not be optimal. So the impact of these frontline choices are very important on relapse. So patients might relapse and we will need to choose a second line therapy for them. So very important to define relapses, whether they have resistant disease, they relapsed on treatment with PD-1 inhibitor, or they had a relapse after achieving a remission. Salvage therapy must account for prior resistance. PET negativity post salvage therapy is the most important thing. Before autologous stem cell transplant, aiming to PET negativity is probably the key in achieving remission. So historically, combination chemos like ICE, DHAB, or GMP, GEGND are more toxic, but given for shorter duration and can be bridged. Brentuximab or immunotherapy like nivolumab or pembrolizumab can be considered. Depth of responses with PET negativity is very important. One point from this slide is that post-autologous stem cell transplant consolidation with the Athera trial is now, we need to select patients carefully for that, because if we are using frontline brentuximab therapy, like BRICAD or BV-AVD, we don't know how post-autologous transplant consolidation, if that will be of benefit, because most of the, or all of the patients in Athera trial were not exposed to brentuximab as first line. So success rate in relapse refractory Hodgkin lymphoma varies with using consolidation or salvage therapy. With ICE, DHAB, 50 to 60% are cured. BV bendamustine or BV nivolumab or BV ICE can achieve 70 to 80% of cure, combining it with autologous stem cell transplantation. Pembrolizumab, GND, or nivolumab ICE may reach to 90% of potential cure. This is a phase 2 study that used nivolumab plus ICE as first salvage therapy in high-risk relapsed refractory Hodgkin lymphoma. So after nivolumab, the overall response rate was 81%, with CR 71%, and 2 years PFS and overall survival were 72 and 95% respectively, showing the importance of adding PD-1 inhibition to your salvage regimen. And probably when the patient is eligible to receive PD-1 inhibitor or brentuximab, the recommendation is to use PD-1 inhibition to the salvage regimen, as it has better CRs and better chance to achieve PET negativity.
1 minute, Dr.
So last 2 slides. This is a study of chemo-free regimen. Brentuximab vedotin nivolumab as salvage therapy can be considered in frail patients who cannot tolerate chemotherapy, although the responses are high, but these patients need to have an autologous transplant as soon as they reach to the remission. So choice of therapy for relapsed Hodgkin lymphoma outside a clinical trial. The preferred regimen for Hodgkin lymphoma when novel agents are available as a relapse disease, ICE plus PD-1 antibody, either Bembro or nivolumab, if not previously received. So if the patient received Nivo AVD as first line, this choice might not be good unless the patient had a remission and then he relapsed 1 year or 2 years later. Repeating PD-1 inhibition is probably acceptable. Should salvage regimen contain a PD-1 antibody? Yes, and preferred if the patient has an access to it. What's the role of consolidation post-transplant? So the role of consolidation with BV in high-risk patients, so patients who are refractory or relapse within 1 year or have an extranodal relapse. Again, we have to look at the previous treatment to judge the benefit as well. So remember, neuropathy is accumulative in BV, so repeating BV in patients who had already neuropathy might be of a limiting factor. So what agent should be used as consolidation? This is probably repeating the same point again. So quick summary. So sequencing now central to cure and survival. Frontline agents, reshape salvage choices. We need to review our own guidelines and align it with personalization. So relapsing after ABVD, BV, or PD-1 based salvage, preferred PD-1 salvage. Relapse after BV, AVD, PD-1 inhibitor plus chemo like Nivo, ICE. Primary refractory disease, combination therapy, and aiming to achieve PET negativity prior to the autologous stem cell transplantation. And thank you.